الرحمن الرحيم. نبدأ الجلسة الثانية بالأستاذ الدكتور مضر زكي الخير الله، ماسف pulmonary embolism.
قبل لا التايمر يبدي نرحب نقيب أطباء البصرة، متشرفنا بحضوره أستاذ عبد الحميد الوصاني. أهلا وسهلا ومرحبا. هسه أنا نبدي التايمر من يمي. تمام. السلام عليكم. اليوم إن شاء الله نتكلم عن acute pulmonary embolism. بالحقيقة أنا بالبداية حطيت التايتل massive pulmonary embolism، بس بعدين قلت هو الأكيوت كله، فshort summarized concise presentation عنه راح يفيد خصوصاً طلابنا الكرام، وإن شاء الله بالإعادة الإفادة للجميع. The clinical problem of pulmonary embolism, particularly in the acute setting, relies on، ومثل ما قلنا هاي طبعاً السلايدات كلها available for anybody who wishes to have them. اكو عندنا هنا فيركوس تراياد اللي هو معروف. الفيركوس تراياد اللي هو الثلاثي مال stagnating blood stasis وهي hypercoagulability و vessel wall injury تؤدي الى thrombosis. اي embolic material within the branching pulmonary vasculature، ومثل الاشجار مثل شو اسمه البرانشز مال الشجره تصغر 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 ويضك، ممكن air ممكن fat، بس usually in this context راح نحكي عنه هو thrombus. الأوريجين اعتيادي من الليمبس والبلفس، و 50% of deep venous thrombosis within the pelvis and the lower limbs will embolize. The incidence is extremely common, 1 in 1,000. 20% of treated pulmonary embolism die within 90 days. فكلش high mortality rate عندنا، ولهذا is an important differential to consider. بس هاي 20% بالحقيقة is often associated with other clinical problems, cancer, sepsis, etc. فهو المريض أصلاً بالفيركوس ترايد متهيئ أنه يودع ممكن احتمال. The true mortality due to undiagnosed PE أقل من 5%, which is good. The clinical problem recovery is linked with the following. من يصير واحد عنده diagnosis of PE كلش ضروري من احنا نبدي وياه العلاج ونحكي عن البروز and cons. اولا مشكله البليدنج due to anticoagulation لا نستهين به. ثانيا الريكورنس وراح نحكي عنه بعدين، لان هذا راح يخلينا نقرر انه ايش قد الديوريشن مال الثيرابي حسب الريسك. وثالثا اللي هو rare 1 in 20 تقريبا 5% of patients نسوي لهم screening in 3 months ورا ما يقد يصير عندهم pulmonary embolism حتى نتاكد ما يصير عندهم chronic thromboembolic pulmonary hypertension. وكلش هذا الديفرنشال مهم انه we don't miss it because the mortality rate كلش عالي and it's a treatable condition. كلش هوايه يصير عندهم pulmonary embolism. ايام زمان شو نقول لهم؟ once they've had the pulmonary embolism نقول لهم 1/3 will go back to normality in terms of physical function, 1/3 will improve but not back to normality, 1/3 will lose their lung function. هسه تقريبا هاي الثيردز راحت. هسه شو نقول؟ آخر البحوث أكو فشي نسميه post PE syndrome. 50% in 1 year راح يكون عندهم functional limitation. فمن يجي المريض إحنا نتأكد ماكو سيتف، نتأكد ماكو other differentials، نطمئنه ونعالج الديكونديشنينج حتى هو يبني لياقته من جديد. الدايجنوسيس challenging بالPE. ليش؟ التشالنج when to test لأنه radiation dose عالي potentially. فيمتى نفكر؟ إذا أكو associated risk factors اللي هي معروفة. Consideration of other differential when the patient is not improving. كان عندي مريض عنده bilateral atelectasis ويا peripheral consolidation. كان disproportionate to the hypoxemia و treated him as pneumonia. هو بالحقيقة عنده pneumonia، CRP مالته مرتفع وفيفر etc. بس ما كان قاعد يتحسن. فمن ما يبدي يتحسن المريض pyroxyphene non-origin يعني other differentials المفروض من ضمنها نحط الPE. 1 in 20 investigated actually have PE. هسه الواحد يقول هاي شنو؟ هاي مضيعة وقت وسيرفيسز وريسورسز، بس هو بالحقيقة إذا أكو life-threatening diagnosis as far as the National Health Service is concerned, it is justifiable أنه if we capture the disease in 1 in 10 to 1 in 20 نعتبره هذا acceptable. إذا قاعدين إحنا capturing the disease in 1 in 4 for example, 1 in 5 معناها we're not doing enough investigations. If we're capturing the disease in 1 in 50 مثلا معناها we are over investigating the patient. 35% of those investigated undergo imaging. فبس ثلث يعبرون هاي المراحل حتى يوصل للإيمجينج. الدي دايمر sensitive but not specific. يعني يفيد إذا negative useless إذا positive. هذا بالlow to moderate probability انتبهوا وياي هذا كلش مهم. إذا البيشنت presenting with low to moderate probability راح يكون الدي دايمر sensitive. إذا high probability الدي دايمر irrelevant. الواحد رأساً يمشي ويا الانفستيجيشن. وطبعاً أكو decision making scores تساعد الواحد حتى هو يقرر أنه do they go on to investigate with imaging or not. اللي هو Geneva score, Wells score, SPEC وهاي متوفرة إن شاء الله بالسلايدات should anyone wish to access them later. ورا ما يسوي السكورينج سيستم اكو فلو تشارت موجوده كلش هوايه بالجايد لاينز الموجوده. هذا ليتست جايد لاين تمشي لو probability intermediate او high probability وعلى ضوء الواحد يمشي. again فلو تشارت موجود for reference later. الراديشن مو فد شيء نستهين به. احنا generally speaking هاي انا اعطيت comparison للماتيرنال دوز الchest x-ray 0.1 whole body effective dose equivalent الى الفنتيليشن perfusion scan تقريبا 1 to 2.5. السي تي pulmonary angiogram 4 to 18. فاحنا يعني ببريطانيا السنوات اللي متوفر بها ventilation perfusion scans preferably young women حتى نقلل الراديشن دوز البريست اكسترا نفضل الفنتيليشن perfusion scan on the assumption عندهن normal lung ما عندهم ما عندهم COPD. اما الاخرين نفضل السي تي pulmonary angiogram لانه not only is it diagnostic اقل يفيدنا بالسي تف أو بالكرونيك إذا كان بالديفرنشال بس يفيدنا with other diagnoses infection, malignancy, etc. that you can capture with this. Treatment هاي هم شغلة مهمة. بالقبل treatment by clot size كان treatment by clot size هسه is not by clot size at all but by clinical presentation. كنا قبل نسميها massive وسب massive. هاي ترى بالحقيقة كلش vague لأنه ممكن مريض عنده multiple subsegmental pulmonary emboli وكومبرومايز يصير ومريضه ممكن عمرها 80 سنه وصار ستيفنس بالبومي فاسكولتشر مالتها وعندها سيجمنتال بي اي بس امورها طيبه. فشو نقول احنا؟ اول شيء من يجي المريض نشوف الريسك مالته. اجى المريض احنا سسبكتنج بي اي نسوي له باسي سكور. زين اذا الباسي سكور مالته طلع فيفربل ولو ريسك نقول له يابا انت امبوليتري بيشنت على ما ندخلك مستشفى نعطيه نواك واوت بيشنت انفستيجيشن ويرجع يكمل. اذا انترميديت right ventricular strain pattern clinically second heart sound بالpulmonary region عالي gallop rhythm ممكن الechocardiogram suggestive of right ventricular strain الCT scan B right ventricular strain pattern البايوماركرز troponin assay أو البرو بي ام بي مرتفعات هذول we have to admit them. نقدر نعطيهم نواك لأن هو short acting novel oral anticoagulant بس أنا أفضل نعطيهم treatment dose low molecular heparin. 5% of those patients ليش ندخلهم لأنه 5% 1 in 20 within 3 days يصير ممكن احتمال عندهم shock و maybe death and they may need reperfusion therapy. catheter directed thrombolysis متوفرة عندنا ببريطانيا بالعراق حاليا ما متوفرة إلا هيك anecdotal evidence بيها. مرة الدكتور أرام قال لي هو مسوي ودكتور وياه بعد كانوا بالنجف هم مسوينها مرة بس not regularly available. الستاديز for central PE شافت ماكو great difference between treatment low molecular heparin against catheter associated. الهاي risk patient المهم 5% of patients 1 in 20 high risk. إذا السيستوليك مالته من دخل نزل جوال 90 mm of mercury أو السيستوليك dropped by more than 40 mm of mercury or more أو ممكن question mark عليها صار أكو rapid increase in oxygen requirement هذا نعتبره in the old days نسميه massive أنا أسميه pulmonary embolism with compromise. المهم شنو؟ أنه هذا الcompromise بالblood pressure is not due to another cause bleeding, sepsis, heart failure فمو رأسا طقينا بثرومبولايسيس بدون ما نتأكد أكو differentials أخرى. Exclude the contraindications active bleeding, space occupying lesion ونعطيهم systemic thrombolysis. Alteplase قسم المستشفيات Tenecteplase قسم المستشفيات الأخرى. وممكن اينوتروب والاكمو راح تسمعون عنه ان شاء الله بالمحاضرات القادمه. تريتمنت باثويز موجوده
دكتور مدر 1 minute
ان شاء الله. زين السبسيكونت تريتمنت احنا اللو مولكيولر هيبرين نستخدم بالبريجنسي. النواك صار حتى باللون كانسر. النواك تشويس نفضل الرايفروكسابان من ناحيه الكومبلاينس لانه once daily treatment dose. ابيكسابان اذا CKD3 الفيتامين كي انتاجونست بالسي كي دي وسي ال دي chronic liver disease والتريبل بوزيتيف انتي فوسفوليبيد syndrome نفضل ذاك. In 3 months إذا وقفنا التريتمنت after 3 months at 10 years 36% will have risk of recurrence, less than 2% fatal, 1.7 in 100 person years يصير عندهم. Other testing ماكو evidence انه نسوي لهم screening for cancer. الشهر اللي فات 64-year-old woman bilateral PE with right ventricular strain تشوفون هنا عندها تقريبا صاير saddle embolism وصاير flat بالسبتم بين الرايت ventricle left ventricle. هذا 71-year-old man bilateral PE long flight قال لي اجى من استراليا ومن نيوزيلندا قبل شهر. نشوف انه كان عنده typical project chest pain. نشوف هامبتون ساين الويد شيب تنفاك بالناكه والويد شيب والفيلينج ديفكت بالميجر pulmonary branch. وهاي المرة كلش خوش مرة حبابة 78-year-old bilateral PE with right heart strain thrombolysis. نزل السيستوليك مالتها 45 all of a sudden on day 2 اعطيناها systemic thrombolysis and she's doing very well almost no oxygen. ونشوف الرايت ventricular strain السبتم كلش مدفوع الرايت ventricle congested وعندها flushing into the liver اللي هو indicating انه هي عندها severe right ventricular strain. وهذا الريفرنس وشكرا جزيلا على اصغائكم.
شكرا جزيلا استاذ مضر. أكرر الملاحظة للشباب أنه put in mind pulmonary embolism in most of your differential diagnosis.
أحمد يوسف ووليد الأنصاري وكاميران أمين عمر. يتفضل الدكتور أحمد يوسف الحاصل على شهادة الاختصاص بالجهاز التنفسي من تركيا ومعادلها بالعراق، يتقدم بتقديم ARDS fluid management. الرجاء دكتور أحمد الالتزام 10 minutes.
السلام عليكم. طبعا صعب جدا ان تصعد على الستيج بعد الاستاذ مضر، صعب يعني، وبهذا الحضور الكريم شكرا جزيلا لكم. لا فرايد ارجع. I will discuss the management or fluid management in ARDS patient in the next 10 minutes. This is a historical summary of the guidelines in acute respiratory distress syndrome. They start from 1967. In 88, they defined the disease as adult respiratory disease until we reach to the Berlin definition. The problem with Berlin definition, we require the use of mechanical ventilation, either invasive or non-invasive, and also we need to use arterial blood gas. In these 2 recent studies, they try to avoid these things to diagnose patients with ARDS. Some words on physiology of ARDS. Patients with ARDS usually tend to have hypovolemia, and this may exaggerate sepsis and multi-organ failure. The opposite direction, I mean, hypervolemia is important and may increase the complication of heart and pulmonary issue. As we just mentioned that ARDS patients tend to have or experience hemodynamic instability. That's why clinicians may tend to replace and give more fluid to maintain systemic perfusion. But we should keep in mind that in patients with ARDS, we have high permeability resulted from inflammation. That's why we should avoid inducing pulmonary edema. In normal condition, the pulmonary capillary hydrostatic pressure is stable with the extravascular lung fluid or water. As we all know that in normal situation, the lung have about or approximately 400 cc or ml of free fluid. But this relation may be disrupted after a certain critical point of pressure. In case of ARDS, the capillary permeability would increase, and this relation would be different, totally different. In, for example, 15 mmHg, the lung water would be different according to the capillary permeability. What is the fluid responsiveness? The fluid responsiveness means the capability of the heart to increase its stroke volume or the cardiac output in response to a volume challenge. Why it is important to assess fluid responsiveness? Because not everyone with shock would show response to the fluid challenge. Not only 48 of these patients would show response to fluid challenge. We need to do tests that dynamically measuring the fluid status of these patients. And we should balance the fluid status because it is risky to give more fluid than the required. And clinical trials showed that the usage of these tests, the fluid responsiveness test, showed improvement in the outcome of ARDS patients. In this study, they show that patients with ARDS, 70% of them are responsive to the fluid challenge, but this percentage decreased gradually. For example, in the 8th hour, only 40% of the patient would be responsive to the fluid challenge. As we all know, this Frank-Starling curve, it's depend on the preload of the both ventricles. In the part, if the heart is working on the steepy part of the curve, this patient would be respond to the fluid challenge. But in this case, if the patient already have higher fluid, this only induce the harm to the patient. As we can see, even minimal increase in the pulmonary capillary hydrostatic pressure would double the amount of lung water, and this would induce lung edema. And this study also showed that extravascular lung water increase will affect the outcome of ARDS patients. We have two types of tests that we can measure the fluid status in our patient. These two types of study, the central venous line or pressure and pulmonary artery catheter, they have problem that they are inconsistent prediction of fluid responsiveness because the body have other parts that fluid can collect it in it. For example, extremities or the pleural cavity before it's showing in the jugular venous pressure. The complication associated with its use of these catheters like infection or pneumothorax and so on. So we prefer these type of dynamic indices of preload responsiveness, including passive leg raising test and end expiratory occlusion test. They are more physiological studies because they are mimic the fluid challenge, but they need to use or to measure cardiac output simultaneously with them. But the last one, which is respiratory variation of stroke volume or pulse pressure variation, there is no need to measure cardiac output with it. So it is simpler, and it's gained familiarity, especially in COVID patients monitoring. This is the arterial pulse pressure variation, and we can see if the patient in steepy part of the curve, so there would be variation in the pressure, while if the patient have higher preload, the variation would be lesser.
Dear Dr. Ahmed, 1 minute left.
Okay, sir. So the higher amount of lung water, the higher mortality in ARDS patient. This is a relatively new guideline which show that the conservative fluid strategies show lesser mortality and even lesser renal complication. So they recommend in weak favor the usage of conservative fluid treatment. I am sorry, I should. And this demonstrates the difference in mortality and even in the ICU stage. This is a new technology. By using transpulmonary thermodilution, they can calculate the cardiac output and the permeability and the water, free water in the lung. This patient, for example, have higher lung water, and the recommendation for this patient is vasoconstriction, not fluid. I would discuss the role of the ultrasound in diagnosis and treatment of or monitoring of the ARDS patient, but unfortunately, I have no time. This is a panel of normal lung. This one is a moderate fluid, which demonstrated by this strict B line gradually until we reach the consolidation with complete loss of aeration. The usage of ultrasound may be as minimum as 4 sections. I am sorry. Thank you.
شكرا جزيلا.
Third lecture يتفضل الأستاذ الدكتور وليد الأنصاري. He will talk about ECMO role in respiratory failure. أهلا وسهلا.
Good morning, everybody. Thank you, Mr. Chairman and Co-Chairman, for this opportunity to speak about the role of ECMO in respiratory failure. احنا الحقيقة بعد مطالبات كثيرة وطويلة وخلال عدة سنوات وصلت 18 جهاز إكمو للبلد وننتظر توزيعها والعمل عليها. Well, ECMO is an extracorporeal technique for providing prolonged respiratory and cardiac support for patients whom they have a problem in their respiratory and or cardiac system in maintaining adequate gas exchange or perfusion to maintain or to sustain life. The story started in 1968, theoretically, but the first patient who connected to ECMO device was in 1971. He is 24 years old, connected to Bramson ECMO, this instrument, and he has a shock lung connected for 75 hours and fully recovered. The principle is just to take, when you have a problem in the lung or in the heart, to take the blood from the femoral vein or any vein, any great vessel from the patient, and get oxygenated and get rid of CO2 and other toxins, and came back again, either to the other venous side or to the arterial. So either VV ECMO or VA ECMO. And the first study who studied the efficacy and economic assessment of conventional ventilatory support versus extracorporeal membrane oxygenation was in 2009 from UK, the CESAR trial. And in this study, they found that there is a survival benefit from using ECMO rather than conventional management. And After that, in the strike of H1N1, the world faced a lung like this when the ventilatory support was very difficult, and there was a study published at that time about the use of ECMO in influenza H1N1. And from that point, the world realized that the real ICU is not a ventilator. We should have these machines as a blood purification system to get rid of toxins and to improve the life of the patients. So for example, if you have, from the hematological point of view, we have the plasmapheresis and other systems. We have CRRT, IHD, ECMO, by its both size, VV and VA. And even for the liver, they have the Mars machine, which improve the organ function. In regard of our talk, the ECLS system, so we have VA ECMO and VV ECMO and VVA ECMO, and even we have the ECOR machine, which help the patient to get rid of excess CO2. Because every minute delay for an intervention in the ICU means that the life of your patient is jeopardized. And here there may be a question may be raised that what's the rationale of using ECMO in respiratory failure? Well, in fact, it to completely replace the pulmonary function in patients dying of refractory hypoxemia or for whom mechanical ventilation become dangerous, and to decrease the intensity of mechanical ventilation. On this busy chart, I'm sorry about this busy slide, it show in details how the ECMO induced the ventilator-induced lung injury, and it reduced the incidence of voliotrauma, barotrauma, atelectatrauma, and even biotrauma. Here, 3 questions has been raised. When we use ECMO, where we use ECMO, and for which patients. When the PRESERVE study has been studied this issue, and they found that whenever you implement it earlier, it will be better. Better result with earlier use of ECMO for such patients. Where we need high flow centers for complex procedure. And they found that the limitation of number of ECMO centers is associated with better outcome. Which patients? Patients with potentially reversible or life-threatening respiratory failure and to optimum conventional ventilatory therapy. And those with severe respiratory failure who's defined in CSER trial by a Murray score. A Murray score composed of 4 issues. It is PF ratio, chest X-ray, PEEP, and compliance. These 4 issues should be calculated properly. And if you have a patient with a 3, get a score of 3 or more, so your patient is eligible for ECMO. Then, in 2018, we have this very important study with extracorporeal membrane oxygenation for severe acute ARDS. They studied the patient and put their inclusion criteria, and they segregate their patients to have ECMO, so using ECMO for patients with the mechanical ventilation and mechanical ventilation alone. And they found as a primary endpoint that there is survival benefit for patients who use ECMO than the control group which use only mechanical ventilation. And the secondary endpoint, which tests the day 16 failure in therapy, and they found that there is a decrease in those patients who use ECMO rather than those who are only on mechanical ventilation. Well, by now, is there contraindications for ECMO? Yes. We have 7 contraindications of ECMO, and we shouldn't misuse ECMO as a machine, as a technique, and we shouldn't lose our resources. 7 contraindications. If you have geriatric patients, with the age more than 70 or 65, massive obesity, severe comorbidity, severe immune compromise, cardiac arrest, especially unwitnessed cardiac arrest. I'm not speaking about the witnessed cardiac arrest when you are working inside the hospital, which is including this facility. Mechanical ventilation duration more than 10 days and multiple organ failure. And if we speak about ECMO, and all of us have many unpleasant memories and, you know, the black days of ECMO. And I'm sure everybody of you has been seeing such lungs with a patient with a white lung and you don't know what to do with him. Let us go, because of the sake of the time, this study from France into 2021, this is from United Kingdom 2022, this is from India 2021, this is from Germany 2021, and this is from USA 2022, and all the studies have been found that there is a clinical improvement of patients and there is survival benefit of patients who are using ECMO rather than not use ECMO. And by numbers, they have a 43% survival rate, better than those who are not using ECMO. البيشنتس اللي كنا نقيس منهم واللي more than 90% الديث طلعوا 43 survival rate, which is very good. احنا مثل ما تعرفون اكو number needed to treat every disease and every study. انا ايش قد اقدر يعني في فتره الاكمو وصلت الى 10% اذا عندي 10 انا كل زين. This is 43 is a great number. This is a real case for 53 years old. I have seen. Sorry, this is the last slide. When we was in Sorbonne in Le Petit Center, I have seen this case. 53 years old female unconscious with severe pneumonia, viral pneumonia. PaCO2 was 90, SpO2 was 60 on admission, PF ratio was 80. This is in the first day, second day, 7th day by VV ECMO. It was survived, and even in Europe, they have ECMO in distant places. So in accident area, this is in the Metro Paris, and this is in the museum. Thank you.
شكرا جزيلا استاذ وليد. يتفضل استاذ كرمان امين. Role of ABG in acute intensive medicine.
Thanks Iraqi Respiratory Association for invitation from Kurdistan. In Kurdistan we will say from Zakho to Basra, and today I will say from Basra to Zakho. So thanks very much. And we have brought about 9-10 doctors from Kurdistan, from pulmonology and respiratory medicine. And today I will speak about the role of arterial blood gas analysis in acute respiratory failure. I am not speaking classical speaking about what is ABG, and I am not here to learn you how you can interpret ABG, but I will show you some slides, some of them the classical student teaching, but I would like to tell you that what are the hidden area or arterial blood gas analysis. My presentation should be the first one in this session, but I am lucky because I am late because they have already spoken about what is the role of arterial blood gas analysis in very critical patients. You cannot decide which kind of patient you have without arterial blood gas analysis. So, okay. Where are the others? The first part. Okay. Okay. Acute pulmonary embolism. I have missed the first part of this slide. Okay. Okay. Yes, it will be. ABG is a mini-invasive procedure. It can be done by nurses and physicians. It's easy, cheap, important, and life-saving. The role of this important life rescue process is still not understood in many places and is still not applied to many emergency departments in our country, from Basra to Zakho. ABG is the only investigation by which we can differentiate between types of respiratory failure. Acute pulmonary embolism, acute heart failure, septic condition, diabetic ketoacidosis, acute lung injury, ARDS, intensive follow-up ICU, CCU is a life-saving procedure. Presence of ABG machines and interpretation of the results by pulmonologists, intensive internists, cardiologists, and other under and postgraduate doctors is a life-saving knowledge. You must have a knowledge about this procedure. And you see, if you follow a patient from an initial event all the way until he or she released from the hospital, you will notice that mechanical ventilator is necessary and used in many areas. For neonatal patient, the mechanical ventilator include oxygen supply too, because it's mechanically ventilated, mechanically oxygenated, mechanically ventilation, mechanically in and out. So oxygen is considered as a mechanically ventilated. It's not just that this patient has no spontaneous breathing. So in this area, what's the meaning of pulmonologist? If you ask any pulmonologist in the world, they have pulmonologist phenomenology in the medical philosophy. They have bronchoscopy. What you done by bronchoscopy is your branch, chest CT scan, pulmonary functions, ICU, CPAP, non-invasive ventilation, arterial blood gas analysis. Without these, without the arterial blood gas, you can, if you go back, non-invasive ventilation, CPAP, ICU, pulmonary functions, chest CT scan, all these, they have connected with ABG if you want. And if you ask, if they have meeting, in the morning meeting or the pre-visit, one of them shouting, I am right, I know everything. And the poor, others, they saw that the person who's shouting, the person, I know everything, and after decades, they show that he was not. And sometimes, now in our country, one or two like that obstacle our development. In arterial blood gas, public health sector has been destroyed. Public health center in whole Iraq has been destroyed. We are just looking for the private sector. Maybe these 18 ECMO machines come to Iraq. I don't know how they deal with this. I will be back to ECMO machine too. And is it ABG or VBG? This is one of the, I'm not speaking about the classical arterial blood gas. I will try to mention the hidden area of ABG. One show you arterial blood gas in the one paper. Ask you, is this a venous blood gas or arterial blood gas? How you can differentiate between venous blood gas or arterial blood gas? This ABG has been done by low pressure heparin syringe or by the syringe washing by heparin. One large air bubble increase PaO2 by 20 mmHg. One large air bubble, you are washing syringe like that. This is wrong. So direct ABG from radial or femoral or by ABG syringe, arterial line, continuous ABG taking, and we have PaO2, PaCO2. The only differences between ABG and VBG is PaO2 and PaCO2. If anybody asks you, really, this is, you have PaO2 of 40, and if you have PaO2 of 55, somebody shouting, this is for venous. How venous blood gas 55 PaO2 will be 55 mmHg? No way. There is no PaO2, there is no venous blood gas PaO2 55. So I hear some doctors, ICU, CCU, they say PaO2 55, this is venous. No way. How we can venous blood gas contain 55 mmHg? Because it is 40. And this is a classical. We will teach students like that. We have blood gas, we have arterial, we have venous, and of course we have AB disorder, respiratory acidosis, alkalosis, metabolic acidosis, and alkalosis is a part. But this is not the aim of the study. The aim, not my talk. My talk is, here in this slide, must be differentiated between venous blood gas and arterial blood gas. And you can differentiate by PaO2 and PaCO2. And this is, I will tell you, this is, must be, all the students know this as her name or his name. Because all assay questions for 6th class or postgraduate pulmonology must have this. pH, PaCO2, PaO2, SaO2. There's a difference between SaO2 and SpO2. Bicarbonate, base excess, and of course we have anion gap and others values. We have respiratory acidosis compensated by metabolic, and vice versa. So we have this. I will tell my students, my colleagues, please remember the word ROM. It means respiratory opposite, metabolic equivalent, or equal. Why? So you can go directly to the diagnosis. This is metabolic acidosis or acidosis, and the vice versa of the direction. And you have the compensation of arterial blood gas, the same as the abnormality of the blood gas. So the direction of compensation will be the same direction of the primary pattern of pathology. And this slide, it is called the journey of oxygen from the atmosphere and the journey of PaCO2 from the cells. And why we are speaking about arterial blood gas analysis? Because we have respiratory failure. And respiratory failure, it means failure in gas exchange. Ventilatory failure, it means failure in gas, ear in and ear out. We have just two causes, high altitude and anesthesia, and if you like to suffocate some person.
So 1 minute left.
Okay, thank you. This is how we have here, we have in this area, it is called external respiration. In this area, it is called internal respiration, cellular respiration. So in these causes of diseases, we have type 1 respiratory failure, acute, chronic type 1 respiratory failure. I asked somebody, really, we have something what is called chronic type 1 respiratory failure? He told me no. And what's about this? Early COPD, lung fibrosis, lymphangitis, carcinomas, right to left shunt, brainstem lesions. And we have chronic respiratory failure like that. And I hear maybe advanced COPD contraindication for ECMO. And so we have not indication for respiratory failure for ECMO. And why they have used ECMO. So I will be back just, okay, this curve 65 in pneumonia must change to, this must be removed. Blood urea, because we have hypovolemic renal failure, and now it's just changed to oxygen. One of the indications of admission for oxygen for hospital, it was PaO2, SpO2 low in COVID-19. You have 92 or 93, 94. Trump treated because of SpO2. One pulmonologist observed SpO2 was 94. So 94 for this man was hypoxia. So now they will change this to oxygen. Acute myocardial infarction. And here, acute myocardial infarction, previously, we told that above SpO2, above 95, no need oxygen. Now they told us, please do ABG on the morning. Maybe this patient has USE or obstructive sleep apnea at night. And if you look here, ABG, CPAP or BPAP, we will change by ABG, machine the treatment for the USE patient. If you have a USE patient, at the morning at 7 o'clock, they have high PaCO2. So this is not indication for CPAP. This is indication for the machine with the inspiratory support. So it is very important. ABG is not the game. ABG is a very critical procedure. And in sleep medicine, in changing models now in Europe, anybody has 2 times myocardial infarction, they will send to sleep analysis. And they will take ABG at 7 o'clock at the morning, because at 2 o'clock will be normal. I'm sorry for, this is ECMO.
2 minutes over.
Okay, this is differentiated between acute lung injury and ARDS. PaO2, no way. You cannot differentiate between ARDS and acute lung injury without arterial blood gas analysis. We cannot, so look to the heart failure. This is which one? This is which one heart failure? Which is ARDS? We don't know. So this is differential diagnosis, imaging, diffuse pneumonia, ARDS, pulmonary hemorrhages. Okay, thank you very much. So this, please, this is very important from 99. This has been used all the world to evaluate intubated patient. This is a normal without chili had bauchimen. Okay, they have got. Yet I'm slide that this is important for ECMO man, doctors here. You have speaking about ECMO, and the contraindication of ECMO above 65. Contraindication for bilateral lung transplantation above 65. And this study, and this slide, where are the slide? I will be back. This is very important things. Yes, please, this is important. Now, if this is the normal, if the age increase, the mortality increase. Age. And after that, the date of intubation increase the mortality. If this man, 70 years old, number of more than 7 days, 17 years old, increase the mortality rate just to normal, healthy person intubated more than 7 days, more than 65 years, that increase mortality more than 30%. Thank you very much. I'm so sorry.
شكرا أستاذ كرمان. المجال مفتوح للأسئلة. For 5 minutes, please.
السلام عليكم. دكتور علي صالح بويعي من بابل. Just I have a question, Dr. Waleed, about the ECMO. As you know, that sometimes we need to use ECMO urgently in IP, in interventional pulmonology, and I remember a lot of cases we lost them, especially if we got a tracheal lesion. So my question, how much I need a time to apply ECMO for the patient? My question is, do I need to prepare myself when I may need ECMO, or I can apply ECMO just with a few minutes? The ventilator cannot exchange the ECMO. I don't know, Dr. Waleed, if you catch me?
Yes, sure.
Okay, thank you.
Thank you, Dr. Ali, for this question. Well, ECMO technique can be used immediately if you would like to use it. Just the time of putting the 2 venous cannulas. So a cannula in the femoral vein and again another cannula in the femoral vein and connected to the machine. The machine should be primed. The machine needs to be primed during half an hour need to be primed. But it should be ready and primed and for use. Catheters are ready. And I have seen patients in Korea. He was admitted from another hospital as a candidate for ECMO. They apply the ECMO within 15 minutes. Just 2 surgeons, one put a cannula here, one put a cannula here, and directly connected to the...
15 minutes is a very long time for
yes,
us.
because you are already putting the tube.
Yes. I remember a patient when I worked in India. It was a low-grade tracheal stenosis, and they operate by a catheter through a ventilation catheter. Unfortunately, the patient developed pneumothorax, and after that, we lost the patient. We lost the respiratory rate. The respiratory arrest. And we connect the patient to the ECMO, but unfortunately we end with the brain damage. And the patient unfortunately died after 4 days in the RCO. So your recommendation is to be prepared.
Prepared,
so
sure.
To be prepared is not an emergency event. So when I work with a patient with high-grade obstruction, it's better to prepare myself for ECMO. I think this is the message.
But it can be used in emergency.
15 minutes, too much.
You are putting oxygen, you are putting a tube for the patient, and you are applying all the emergency procedures. It's just to help you.
Okay, thank you.
Thank you.
Emergency and non-emergency.
It is already used in emergency.
الانترفنشنز مثل ما تفضل الأستاذ علي.
Even in cardiac arrested patients.
No.
Even in cardiac arrested patients, witness cardiac arrest, you can put the tube, in the tracheal tube, you are securing the oxygenation for the patient and doing the cannulation rapidly and can be connected.
أستاذ علي نركز على نقطة مهمة بالintervention, pulmonary intervention. We have sometimes a bloody field, very high bloody field. لما ناخذ biopsy, لما نشيل tumor من trachea, bronchi, bloody field and it will close all the bronchi. You have no time to have sections actually. Patient develops severe hypoxemia and may develop arrest. واحدة من الindication تفضل.
Do you suspect it or not?
Yes, sometimes suspected.
The question here, if you are suspecting that your patient will need this intervention, you should prepare yourself.
Prepare.
And even you can put the cannula. And when you need it, you can directly connected. الموضوع كله يعتمد على توفر الاشياء. اذا الموضوع متوفر مثل ما انت هسه مريض تتوقع انه يعني انت بكل صاله هسه اكو دي سي، تتوقع اي وقت ممكن يصير الرست. فانت اذا متوقع ومريضك تشوف هذا فانجيتنج تيومر وممكن يصير عندك مشاكل، حتى ممكن تحط الكانيلي وترتب امورك تشتغل، احتاجيته وكونكتد، ما احتاجيته وقيت.
عاشت لي، شكرا، معلومه كلش مهمه هذه، عاشت ايدكم.
كلام يعني بدون ما نفوت بالديتيل. الدكتور قال صار نيموثوراكس، فانا ما اعرف نيموثوراكس شنو علاقته بالايكمو. نيموثوراكس ينحل تشست تيوب فيري سمبل بروسيجر. جنابك قلت اذا اكو pulmonary procedure يصير بليدنج، اذا اكو بليدنج هو ريليتيف كونترا انديكيشن للايكمو، لان انت بالايكمو لازم تنطي هيباري وتصعد الاي سي تي الى ليفل حتى ليس عندك
انترا برونكيال بليدنج.
فاذا صار عندك انترا برونكيال بليدنج لازم تتعامل وياه بغير شكل، يعني تخلي سلكتيف انتوبيشن، دبل لومن انتوبيشن، اند برونكيال بلوكر. ما اعتقد ايكمو هو فد جود تشويس لهالحاله.
اعتقد هو يوز از بريدج، يوز از بريدجنج تايم.
نو دكتور، نو هيبرنايزيشن راح يصير عندك هو ريليتيفلي كونترا انديكيتد، يعني ما اعتقد هو فد جود اوبشن.
البليدنجز اللي كان المقصود به استاذنا هو انه لوكال بليدنج when you are removing tumor from the trachea from the large bronchi. Bleeding will occur intrabronchially not in the cyst, not
تقدر تخلي دبل لومن ايزوليشن اوف ذا لانج، تسوي سيبريت سكشن حتى اذا عندك لانج وحده صاير بها توتالي كلوز.
sometimes not successful. sometimes not
تفضل
successful.
دكتور.
لا ممكن اجاوبك. لا دكتور، هو مو هيك السؤال. هو السؤال انت هذا البليدنج
نعم.
is it medical or surgical؟
جنابه قال بالانترفنشن، فبدا انترفنشن انت
اذا هو هسه سيرجيكال والمريض تايرد انف انه بس يريد يكمل، يريد يشتغل، ترى انت حتى تقدر تحط هسه احنا نحط CRRT وممكن ينحط حتى الايكمو اذا مريضك كان عنده ميديكال بروبلم وما تقدر تخلي له، انت ممكن مريض ما تخلي له على انتي كواجولانت، يعني مريض اللي عنده بلد دياتيسز وعنده مشكله بالكواجوليشن وعنده بليدنج ممكن تخليه بدون انتي كواجولانت.
مفهوم دكتور،
القصد انه اكو اني اللانج، بس اسمعني، اللانج اريد اوقف ما استعملها هسه.
نعم.
اريد اكمل البروسيجر مالته.
دكتور احنا نسويها، عفوا بس جنابك اذا تنطيني مجال احنا نسويها، احنا ككارديو ثوراكس سيرجن نخلي المرض على باي باس، اذا نريد نوقف اللنج او الهارت هي نفس البرنسبل. بالضبط. فاذا انت عندك جنابك سويت بروسيجر باللنج صار عندك بليدنج، انا ما اعتقد الايكمو هو حل مؤقت لك، لانه البليدنج ما راح يعطيك مجال، راح تنطي له هيبارين.
مو حل البليدنج دكتور، مو حل البليدنج.
مو الدكتور قال عندك بليدنج ما راح يصير. اذا اكو بليدنج باللنج هي مسج يعني بس حتى نوصلها للاطباء، اذا اكو بليدنج باللنج نتيجه اي انترفنشن the best thing هو to deal with intobronchial blocker, rigid bronchoscopy, double lumen, isolation of the lung, etc. وليس الايكمو وتنطي هيبارين. اعتقد
صحيح
اكيد والاي بي سي متفقين عليها. Sometimes with rigid, with double lumen, the bleeding is very severe and the hypoxemia will be very severe.
اي هذا يجي دور الثوراسك سيرجن، يعني راح يتحول مرضى ثوراكوتومي اعتقد، لانه ما
تايم
اللي اذا تنطي هيبارين خليه على الايكمو. البليدنج اذا تقول هو سيفير الشكل بالعكس
وهذا طبعا يعني مع وجود الثوراسك سيرجن احنا ما نشتغل بدون ثوراسك سيرجن، هو يمنا واقف.
لا هي بس مسج يعني حتى للفيزيشن، اذا سويت بروسيجر صار عندك بليدنج الايكمو راح تزيد البليدنج، لانه انت مو بس الهيبارين دكتور، ما تخلي البيشنت البلاد يروح على السيستم، راح يصير عندك بليتلت ديستركشن، يعني ورا فتره حتى انت يعني كانه بدها تنطي انت بليتلت للمريض، فالبليدنج بروفايل راح يزيد عند المريض. اوكي شكرا جزيلا.
شكرا جزيلا استاذ، شكرا عاشت ايدك.
Another question. تفضل استاذ عباس. منو عنده سؤال؟ نعم تفضل.
شكرا جزيلا دكتور مصطفى. سؤالي الدكتور أحمد. You have approached to fluid management by fluid responsiveness. As we know, the patient in ICU or respiratory care unit more liable to fluid overload. I think to go to approach of fluid tolerance rather than fluid responsiveness to overcome the risk of fluid overload. Fluid tolerance, we assess the patient by echo and by capillary wedge pressure, by the lung, by the volume overload, and then we'll give him the fluid which is needed and to avoid fluid overload اللي هو more level. While in patient with the fluid responsiveness, we give the fluid according to the dehydration state, according to the urine output, according to the need pulses of fluid between 250 ila 150 cc, ila 500 cc, according to the dehydration state, hypovolemia, urine output. We have to approach and this patient. I think the approach to fluid tolerance is more acceptable in a patient with in ICU and respiratory distress.
Totally
Thank
agree.
you very much.
Totally agree. Thank you for your comment. يشتغل؟ هي المشكلة الدلمة أنه بين الهايبوفوليميا والفوليوم اوفرلود أكفد شعرة بسيطة. المشكلة يعني these patients have inflammation, have higher permeability. Even with shock patient, he have also a volume overload, which may be found in as free fluid in lung or pleural cavity. And some of these tests, the static or classic one like CVP, pulmonary catheter, and even the clinical signs is not enough because these patients have different, even with hours, they converted from totally responsive to the fluid to not respond. So it is a difficult situation. That's why we should use echo, ultrasound, and even new technology.
I think the requirement for assessment of fluid tolerance is more difficult as not available at any time. قياسا مثل نحسب left atrial pressures, نحسب left capillary wedge pressure, لازم central venous. أعتقد requirement so difficult to assess. مع ذلك احنا in patient, such patient with comorbid disease and admitted in the RCU, I think the approach to fluid tolerance is little bit better than fluid response. Thank you very much, Dr.
شكرا جزيلا.
Assalamu alaikum.
Last question.
I'm Dr. Basil. I'm from RBL. Regarding the ECMO, actually, if you have, just for IP doctors, if you have a case with, for example, metastatic, for example, any kind of carcinoma that infiltrating the trachea.
بس قرب على المايك ترى صوتك ما واضح.
Okay. If there is any kind of cancer that infiltrating the trachea, I mean, if there's a central area obstruction, just for palliative care. In central area obstruction, we can use ECMO sometime, definitely, and it's not contraindicated. And I'm saying that these kind of patients that are surgically unfit. That's why, for example, if you have a patient central area obstruction, you want to put a mass, a stent, and the patient is severely hypoxic with low FiO2 that you cannot just go on. You can just put on the VV machine, for example, ECMO for just like for 45 minutes, and then you can go on. And definitely it's not contraindicated. This is one. Second, regarding the ECMO, do we can just use for every kind of patient, for example, for severe ARDS or just moderate ARDS, or even in case of mild, we can use it?
To answer your question, you would like to use it as a therapy or a bridge?
As a therapy, different. For ARDS,
بس
we can.
اي فالار دي اس هو ثيرابي.
Yeah.
بس مثلا للبيشنت اللي قلت عليه مثلا هو عنده فد بروبلم ان ذا لنج and you would like to do مثلا lung transplant or even cardiac transplant، لا هذا بريدج، فانت تقدر تخليه. انت مثل ما تفضلت ماكو عندنا مشكله، ممكن تخليه وبعدين بس هو to be used in CA and multiple comorbidities, and especially if you have geriatric patients, it would be difficult to be done like that. تدري انت يعني مثلا في بريطانيا الى حد بدايه الكوفيد only 8 centers of ECMO in UK. دائما هي هاي تدري يعني الاماكن مو فد تكنيك ايزلي وهيك لاي واحد تخليه، فشويه لازم ينحصر الانديكيشنز وتكون بشكل. انت هذا السي اي لازم تعرف انه it is not disseminated and واكو هواي كرايتيريا بيها بالموضوع. على العموم, if you would like to speak about that, we can talk about that for days. The indications can be even tailored from country to country according to the availability of the machine. Okay?
Yeah.
So it can be used for the RDS for the second question.
Yeah, the last one, just what about the price for ECMO? I mean, each session, the
price هو الجهاز ممكن ينطي free بس السيشن يكلف about 5 مليون دينار يعني إذا إيراكي دينار يعني السيشن. هسا احنا عندنا مثلا السي ار تي ده يكلف مثلا about 3 مليون دينار a day. لا العفو مو 5 مليون a day. هو السيشن يكلف 5 ملايين. السيشن اللي ممكن السيشن هذا يكون اسبوع 10 ايام. even اكو بعض الفلترز can take 6 weeks. You put your patient 6 weeks upon this machine. هو يعني مثل ما قال الدكتور هو مثل الهارت لانج ماشين. But it can be used بشكل مختلف آخر يعني بشكل أبسط.
It is limited and costly should be targeted to special population excluded cancer and unfortunate patient. Now welcome to a representative from Pioneer, one of the sponsor company for this conference for her representation. I will get the chance of this 30 minutes. I thank my colleague Dr. Mudher. He have shortage of time. Initially, also something changes about the prophylaxis for future pulmonary embolism. You say high risk, low risk. Even the recurrence, say provoke or not provoke. This now is also omitted. Now, high risk of recurrence and low risk of recurrence, for according to the duration of follow-up.
بالبداية شكرا جزيلا على الدعوة لشركة بايونير. أعرفكم بنفسي، أنا دكتور علي جبار PhD فارماكولوجي أند توكسيكولوجي وماركتينج أند سيلز مانجر شركة بايونير في العراق. اليوم ما راح أحكي على بايونير برودكتس، اليوم راح نحكي كبايونير مانيفاكتشرر، وراح نتكلم على التكنولوجي والمودرن تكنولوجي اللي تستخدمها مصنع بايونير بإنتاج البرودكتس الخاصة بالشركة بايونير. طبعا جميل إنه إحنا نفتخر بأطبائنا العراقيين زين اللي منورين بكل العالم، وإشادة كبيرة بأطبائنا وجودة التعامل مع البيشنت والكواليتي مال التريتمنت. بنفس الوقت أنا صار لي 4 أشهر بالشركة. إحنا لازم أيضا نفتخر بالمنتوج الوطني والصناعة الوطنية، وشركة بايونير هي واحدة من الماستر بيس الموجودة فعلا بالعراق، ويمكن عدد من الأطباء زاروا المصنع وشافوا الكواليتي والمودرن تكنولوجي اللي قاعد يستخدمها المصنع بالصناعات الدوائية. اليوم الفارماسيوتيكال اندستري is a machine matter. It's not a human made product. فالموضوع كله متعلق بالماشينز. شركة بايونير موفرة ماشين راح نشوف من خلال البرزنتيشن من international companies، وهاي الانترناشونال كومبانيز هي نفسها تستخدمها شركات عالمية ثانية. فاليوم الكانتري والاريا اللي موجود بها المصنع ما يمثل فقط البلد نفسه، لكن شركة بايونير انشئ المصنع مالتها على مود يغطي سوق الدواء العراقي. وبنفس الوقت راح نشوف بنهاية البرزنتيشن أن الشركة لأول مرة بتاريخ العراق تصدر أدوية إلى خارج العراق، وفعلا قدرنا نصدر أدوية لمنطقة الخليج. مثلا عندنا دولة عمان ودولة الإمارات العربية المتحدة. شركة بايونير أول شركة منتجة للأدوية فارماسيوتيكال اندستري صدرت إلى الخليج، وأيضا كملنا التسجيل في الأردن، وإن شاء الله أيضا نتوسع على منطقة المينا ريجن. طبعا هذا المصنع يمكن جزء من حضراتكم زايرين المصنع، فيري هيوج فاكتوري، طبعا بعدة أقسام. عندنا سيفالوسبورين، مصنع خاص فقط بالسيفالوسبورين. شركة بايونير هي الشركة الوحيدة اللي توفر كل منتجات السيفالوسبورين موجودة بالعراق. Our vision very clear vision. الشركة عندها فيجن كلش واضح، نريد نسوي اكسبانشن، نريد نغطي سوق الدواء العراقي بمختلف الثيرابيوتيك كاتيجوري. وفعلا كشركة اليوم عندنا أكثر من 216 برودكتس يغطي معظم الثيرابيوتيك كاتيجوري الخاصة بأطبائنا. Our values طبعا نركز كلش هواية على respect our customers, our doctors, our partnership، كل اللي نتعامل وياهم integrity and leadership, passion and result. Who are we؟ طبعا الشركة انشئت بال2008 مسجلة في وزارة الصحة، ومن ذاك العام هي بدأت تنتج عدد من المواد، لأن اليوم وصلنا إلى أكثر من 216 برودكت. الشركة تغطي معظم احتياج وزارة الصحة العراقية، وأيضا المستشفيات والمؤسسات الصحية الموجودة بالبلد، وأيضا تغطي بحدود أكثر من 7% حاليا من السوق الدوائي بالقطاع الخاص، ونطمح انه احنا هاي السنه نغطي اكثر من 12% بعد الاجراءات الاخيره لوزاره الصحه. يمكن حضراتكم اطلعتوا اخر 3 اسابيع وزاره الصحه بدات تركز على الادويه المغشوشه، طبعا هاي معضله كلش كبيره موجوده بالسوق وقاعد تسبب ليجل ايشوز العدد كبير من الصيدليات وايضا المذاخر، فلذلك الادويه الخاصه بشركه بايونير والشركات الرصينه اللي تكون مسجله ومفحوصه هاي توفر غطاء قانوني لكل اطبائنا الاعزاء وايضا زملائنا بالصيدليات على مود تبعدهم عن اني ليجل ايشوز ممكن يتعرضوا لها، لان بالفتره السابقه خلال 3 اسابيع الاخيره وزاره الصحه مع الجهات المختصه غلقت عدد كبير وسحبت عدد كبير من الشركات. احنا اليوم شركه بايونير موفرين الادويه بشكل مسجل ومفحوص، ونقدم سيرفيسز كلش عاليه على مستوى الترانسبورتيشن، الستورج، هاي جدا مهمه بالصناعه الدوائيه. ويمكن حضراتكم اذا زايرين المصنع مالتنا والمخازن راح تشوفوها على ستاندرز عالي، وكلها هي تحت تفتيش وزاره الصحه، وشوف دائما يعطونا كتب شكر بهذا الخصوص. طبعا الشركه حاصله على اول شركه حاصله على CGMB. CGMB اللي هو Good Manufacturing Practice. السي هو يعني الكرنت. شركه بايونير التكنولوجيا اللي تستخدمها بصناعه الادويه هي تكنولوجيا حديثه، يعني كرنت GMB، وهذا الشركه الوحيده الموجوده بالعراق وزاره الصحه مطتها هاي CGMB. حالها من حال الشركات العالميه اللي تزورها وزاره الصحه بمختلف الدول وتعطيهم هاي السيرتيفيكيت على مود يعملون بالعراق. طبعا عندنا اكثر من 1000 موظف موجود، عدد كبير من عندهم بالمصنع وايضا عدد خاص بالتسويق بكل محافظات العراق. ايضا عندنا ديبارتمنت كلش مهم اللي هو R&D Research and Development Department. شوفون شركه بايونير يعني annually developed not less than 10 products. هاي السنه ان شاء الله راح يكون عندنا ريفاركزبان موجود، تيكا جريلور، وايضا عدد من البرودكتس المهمه اللي يستخدموها اطبائنا مختلف المجالات. ايضا regarding الكواليتي، الشركه عندها كواليتي كنترول ديبارتمنت وايضا عندها كواليتي اشورنس ديبارتمنت. يكون اكو دبل تشيك على اي باتش يطلع من المصنع، بالتالي شوف معظم الباتشز اللي تطلع لوزاره الصحه هي ما يكون عندنا بها اي اشكال، ودائما تكون من يكون لها فحص مره مرتين ثلاثه وبعدين يعفونا من الفحص بعد ما يشيكون ان الكواليتي تكون بشكل عالي. ليش؟ لان عندنا دبل تشيك، عندنا كواليتي كنترول ديبارتمنت خاص بالمعمل وبنفس الوقت عندنا كواليتي اشورنس، هذا يتشيك بعد الكواليتي كنترول ايضا. طبعا بس نشوف الكباسيتي، هاي جدا مهمه اطبائنا الاعزاء. شوف الكباسيتي مال المصنع والفاسيلتيز اللي يقدر المصنع لحد الان يشتغل بطاقه 30%. المصنع انشئ بالعراق على مود يغطي العراق ويغطي المنطقه كلها، ودائما انه احنا نطور بقدرات المصنع. فتشوفون على مستوى التابلتس بليونز اوف تابلتس الكباسيتي مال المصنع، واذر دوز فور مليونز الكباسيتي مال المصنع. هذا يمثل قوه المصنع وبنفس الوقت الطاقه التصنيعيه اللي يقدر من خلالها يغطي كل السوق العراقي. وايضا اذا نشوف هنا عندنا الماشينز اللي يستخدمها المصنع هي رومولج وبوش ودلمة، كلها من مناشئ ألمانية وإيطالية، ويستخدموها شركات عالمية أيضا مختصة بالصناعات الدوائية. هذا البورتفوليو مال الشركة أيضا حضراتكم تعرفوه، وتكلمنا على الثيرابيوتيك اريا اللي هي تغطيها الشركة، معظم الثيرابيوتيك اريا تغطيها الشركة. وأيضا النقطة جدا مهمة نحب نأكد عليها أن الشركة لأول مرة شركة عراقية مختصة بالصناعات الدوائية قدرت تصدر خارج العراق إلى دول مثل عمان والامارات، وايضا ان شاء الله رايحين الى الاردن. تعرفون ذول الستاندرز مالتهم كلش عالي وما يقبلون اي دواء الا يكون الكواليتي مالته عالي جدا. وشكرا جزيلا. ثانك يو فيري ماتش.